thank you very much, Internet, for this very kind introduction. It's really a pleasure to be here and an honor to be here. I'd like to start, by expressing my condolences for the loss of your late king. So today I'll speak about the HIV reservoir, as Internet mentioned before. You know that we have good drugs to treat HIV infection, and they work pretty well. And actually, if you give these drugs to HIV-infected people, you can improve the life expectancy considerably. So here on this slide, I'm showing the life expectancy of people who were infected in 1996 or 1995, before the antiretroviral therapy or the triple therapy era. And you can see that the life expectancy of a 20-year-old person was around 8 years at the time. Right now, in 2016, we have estimated that people living on triple therapy have a life expectancy that is comparable to the one you would see in non-infected people. So really a great success of modern medicine, and these drugs work well, they have less side effects, they are very efficient, and they considerably, again, increase life expectancy. So they do all that, but still they don't do everything. And even if people taking drugs can live for longer, there are many problems that remain with antiretroviral therapy. The first, if I can do that. So there are, in my opinion, 4 main issues that remain in people who are under triple therapy. The first is that even if you're treated with antiretroviral therapy and your viral load is undetectable, the stigmatization and the criminalization of people living with HIV will remain. And this is something that I also see in my country, in Canada, where at some levels, HIV infection is still criminalized. Second, these drugs have some side effects, and we don't really know the very long-term side effects of antiretroviral therapy. We're just discovering year after year that if you take these drugs for a very prolonged period of time, some of these side effects may appear. The third problem is that not everybody on earth has access to antiretroviral therapy, and in some countries it's actually quite hard to give antiretroviral therapy to everyone. And if that's not enough for you, if you want an economic reason for why antiretroviral therapy is not perfect, there is an economic reason. These drugs are quite expensive still, and the follow-up of the patients on antiretroviral therapy is also quite expensive. So we need to do better than that, and better than antiretroviral therapy is actually trying to eradicate the virus. The problem is that these drugs do not eradicate the virus, and we know that from 1997 when the first interruption study was conducted, and what all the clinicians have seen is that when people interrupt antiretroviral therapy, the virus comes back in a few weeks, as Jintanat mentioned in the previous talk. And it comes back at levels that are actually quite similar to the levels before initiation of treatment. So it's pretty much like if treatment didn't do anything in the meantime. And so we know that the virus is persisting because of this clinical evidence that it can rebound. And I'm not sure I can point that, but that's fine. I can use this. Can you see my, yeah. So clearly if the virus comes back here, it's because it was persisting here somewhere during all this phase when the patients were under treatment. So the job of many people in the world, including my job and the people working in my lab, is trying to understand where the virus is persisting, how it persists, and is there a way we can really get rid of it when it's at such a low level. So it's a complicated question because the virus is actually able to hide and persist in many different places of the bodies. So we have identified in the past, not only us, but many people in the field, that HIV is able to persist in the brain. It can also persist in lymph nodes. It can persist in the gut, and it can persist in the genital tract. And as you know, these compartments are not easily accessible. So it's complicated to quantify the reservoir and the virus remaining in those compartments, and even more complicated to design strategies that could eliminate the virus that is persisting there. So what are the mechanisms by which HIV persists in these tissues and in these cells? First, and I think maybe the one that is the most easier to understand, is the fact that some of these drugs to treat HIV do not fully penetrate in some tissues. So even if you give triple therapy to HIV-infected people, sometimes the concentration of drugs that are necessary to completely inhibit viral replication are not reached in some tissues. And that might be the case actually in the lymph node and in the gut. So this is what I call the active reservoir. It's the inability of of some of these drugs to really reach the optimal concentration of these tissues that gives a chance to the virus to continue to replicate at low levels. And this is actually quite controversial. And if you put 100 people in a room asking them whether or not there is still ongoing viral replication in people on triple therapy, it's probably 50-50. I believe it probably happens in some patients and not in others. But what everybody agrees on is the fact that there is this latent reservoir that is established quite early in infection, in which the virus is basically asleep. So some cells get infected and the virus will hide in these cells in a sleeping way, I would say, and it can persist for decades in these cells. And these cells can persist through two different main mechanisms. Either these cells will survive for a very long period of time, so for decades, or they will slowly proliferate. And this is something that we have learned in the past 10 years, that these cells have the ability to proliferate with HIV sleeping inside. So the major difficulty again in this field is the rarity of these cells. We estimate that the size of the reservoir is around 1 in a million. So that means that you really have to pick the white flower without touching all the green flowers around. So if you really want to eliminate HIV, you have to kill one cell in a million, and it has to be the good cell. So of course it's extremely challenging. Not only that, so the cells are rare, but also extremely long-lived. So some of the studies conducted by Bob Silicano and actually Diana Finzi is in the room today, in some of these studies they measure the half-life of the reservoir over time. And if you do so by using this very complicated assay, and I'm not going to go into details, you can see that it would take more than 70 years of triple therapy to eradicate or possibly eradicate the reservoir, which obviously is not feasible. So we need to accelerate the decay of the reservoir to get rid of this remaining virus. So what are the cure strategies that have been developed or that are currently under development? The first one is to treat people very early on, and Jintanat just mentioned in the previous talk how efficient this is. So if you treat very early on, you can considerably reduce the size of the reservoir. There are other strategies that have been developed to reduce the size of the reservoir once it's established. So the first strategy is to render uninfected cells resistant to HIV, and I will show you that in a minute, or to deplete directly infected cells. You can imagine that if you have a marker for latently infected cells, so for the reservoir, you could directly go and try to kill them. And the third strategy, which is called the shock and kill or kick and kill, the idea is to flush out the latent reservoir, and I will show you that also in a minute. And the idea is also to combine that with immunological strategies to boost the immune system. So we believe that you need two things to eradicate HIV. You need to reduce the size of the reservoir, but you need also to boost the quality of the immune system so it can control the remaining virus. And I'm not going to speak about this today because I believe that Lily and others will do later on. So again, early ART is probably the best way to impact the size of the reservoir. And we've shown that, others have shown that also, and this is the result from the study that we have been conducting here in collaboration with the military HIV research program, the Thai Red Cross, and many people in this room, showing the size of the reservoir in people who have been treated very early on or later. So here on this graph you see the size of the reservoir with one of the assays that we are using, and this is the time in weeks after treatment initiation. So all these participants started out here at week 0, and we followed the size of the reservoir. So if you start antiretroviral therapy in chronically infected individuals who have been infected for more than 1 year, the reservoir is already established and the treatment has a very minimal impact. And you can see that the reservoir is quite stable with time. But if you start antiretroviral therapy early on, in the first, let's say, 3 months post-infection, then the reservoir to start with is much lower or much smaller. Plus, you can see this decay in the size of the reservoir that you won't see in people who start in chronic infection. And most dramatically, if you look at people who have initiated antiretroviral therapy within the first 17 days post-infection, we just can't see the reservoir established in the blood at this time point. So it's extremely low, and it remains low, of course, all the time. So clearly, there is a benefit of initiating antiretroviral therapy very early on to limit the size of the reservoir. So one of the strategy once the reservoir is established, because not everyone can start antiretroviral therapy very early on. So when the reservoir is already there, what should we do? So the first strategy, or one of the first strategy, or most promising strategy that has been developed to clear the latent reservoir is to render uninfected cells resistant to HIV. And the idea is that if you do that and then you stop antiretroviral therapy, the virus won't have any target cells. So basically the virus will disappear with time. And so this has been done by Pablo Tebas and others and published 2 or 3 years ago now. And the idea was to really modify CD4 T cells, which are the main targets for HIV infection, and render them resistant to HIV. So the way you do that is that you're getting your patient and getting a leukapheresis from these patients, so lots of blood cells and lots of CD4 T cells. You're getting the CD4, put them in a culture dish, and you modify them using what we call the zinc finger. So the strategy is really to disrupt one of the receptors that is necessary for HIV to enter the cell, which is called CCR5, the co-receptor. And when the cells are protected, then you put them back in the patient. So you infuse these cells that are protected, and then you see what happens. And so they've done this experiment, and these are the preliminary results. And this has been done actually in collaboration with Sangamo and Rafik Sekali, who provided this slide. So what they observed in these 9 participants is that in 6 of them, the decay in the size of the reservoir was really accelerated to what you would have expected in people not undergoing this intervention. So it's accelerated decay but no eradication. Clearly the reservoir is still there, but I think it's a good sign that you can actually impact on the half-life of the reservoir by performing such an intervention. So very promising. So the second strategy I'd like to talk about is what we call the shock and kill, or the kick and kill. So here the idea is to get rid of the reservoir by reactivating the virus that is asleep in the cells. So if the virus is sleeping, it's basically invisible to the immune system, and it can persist for a very prolonged period of time. So if you wake him up and if you tell the virus, I want to see you, then the immune system will see it, and most probably will be able to eliminate these cells. So this is what we try to do in this strategy. This is a latently infected cells, so sleeping virus. You use what we call those latency reversing agent, or LRAs, and these drugs have the ability to reactivate viral production from these latently infected cells. And when the virus is reactivated, these cells will most probably die, either because the virus will kill it or because the immune system will recognize this cell and will eliminate it. And at the same time, you maintain antiretroviral therapy. You maintain antiretroviral therapy, so even if the virus is produced, it will not go into new cells. So basically, you're flushing out the reservoir or purging the latent reservoir without infecting new cells. So this has been tested in vivo in many different clinical trials, and Sharon Lewin is here, and she's actually contributed to many of these trials. The first one was conducted by David Margolis in North Carolina, and they used vorinostat, or SAHA, which is a class of molecule that is called histone deacetylase inhibitors, and these molecules have been given to cancer patients in the past, and they have shown some ability to reactivate HIV from the latent reservoir. And they do, because if you look in vitro, you can see some viral activation. I'm not going to go through into details here, but just to tell you that there are several molecules that have this ability to wake up the virus. So it seems that they work quite well in the cells and they can reactivate the virus. But even if they do so, they have no impact on the size of the latent reservoir. So everything seems like you're getting some reactivation, so the cells are making a little bit of virus, but these cells persist and are not eliminated. So there is something that really doesn't work in the shock and kill strategy, and that we still do not fully understand. So we need to understand why these strategies do not work, and we still have a lot of work to do, but there are many hypotheses that have been proposed for the failure of this clinical trial. Clearly, those latency reversing agents, or LRAs, are quite inefficient at reducing the reservoir, and this might be because they do not reactivate HIV in all cellular reservoirs. So you might imagine that some of these molecules do not go into some tissues that are important for HIV persistence, for instance. They also probably need to be used in combinations. We know that in some of these cells you need to really use a hammer to wake up the virus. In other cells, maybe a less strong molecule would have the same effect. So there is some variability in the capacity to reactivate latent HIV. And finally, the possibility is that even if these cells are reactivated, maybe these cells are, the virus is reactivated, maybe these cells are not killed because your immune system is not strong enough to eliminate them. So we actually developed in the lab an in vitro system to measure the ability of this latency reversing agent at waking up the virus. And what we observed is that it's actually very difficult to wake up the virus from latently infected cells. We used different drugs that have been used in clinical trials in the past and observed that most of these drugs are largely inefficient at reactivating the virus. We have some good candidates that seem to have some effects. So here we are measuring the level of HIV reactivation, and these are the different drugs we have tested. This is the positive control, so pretty much all the cells get reactivated with this. This is not something you would give to patients that would kill them, so clearly this is just a positive control in vitro. And we use some of these molecules that you could actually imagine to put into patients, and some of them actually have quite of a nice effect, but not as strong as the one that you would see with the positive control. So how do we target all latently infected cells? Again, the shock and kill strategy is promising, but it seems that you will not be able to reactivate all the reservoir using that, so we need to develop other strategies. Again, I think those latency reversing agents have many limitations, and I'm not going to go back to that again. So the main questions we have been asked in the lab for probably 6 or 7 years now is, can we identify markers that are specific to these latently infected cells, markers that we can target to eliminate those cells in which the virus persists. And so we had an hypothesis. The hypothesis is that usually when HIV infects cells and CD4 cells, these cells are being killed, right? They are being killed just because the virus is going to kill them or because the immune system is going to recognize these infected cells and eliminate them. So if the virus managed to get asleep and to hide in some cell, there has to be some signal that is very specific to these cells in which the virus can hide. And so that was the hypothesis, that in some cells, and a few cells only, there will be a negative signal that will tell the virus, go to bed, sleep, don't wake up, and these cells would be the best way or the best places for the virus to hide under antiretroviral therapy. And so the candidates that we had as molecules that could have this effect are called immune checkpoint molecules. So these molecules are expressed by CD4 cells and other cells, and they can deliver a negative signal to the cell. So basically they tell the cell, you should rest and get asleep. And they would tell the virus exactly the same thing. So these are good candidates for cells in which the virus would be able to establish latency and persist. So these immune checkpoint molecules are very well known in infectious disease and cancer, because if you use antibodies to block these molecules, you can restore immune function, because basically you're waking up the cells, waking up the immune system, and boosting immune capability. So we hypothesized that those molecules can contribute to HIV persistence by contributing to the establishment of latency and contributing to immune dysfunction. So Rémi Fromentin, who is a postdoc in the lab, did these experiments, and we actually measured in collaboration with UCSF, Steve Dix, and Sharon Lewin. We measured the expression level of different of these immune checkpoint molecules and compared the expression of these molecules with the size of the reservoir. So the y-axis is the size of the reservoir, the x-axis is the expression level of these molecules. And even though the correlations are not that strong, we found that 3 out of the 8 molecules we screened for are actually positively correlated with the size of the reservoir. And so we performed this experiment in which we purified or isolated the cells expressing these immune checkpoint molecules and asked the question whether or not we would find virus inside. And the answer is yes, and actually the more these cells express these immune checkpoint blockers, which are called PD-1, LAG3, and TIGIT, and the more likely you are to find virus inside these cells. So that was nice, and we thought that maybe we had a combination of molecules that could identify persistently infected cells, but the most important question is, can we manipulate those molecules to actually wake up the virus? So this is something that we've tried to do in the lab. So this is the hypothesis. Usually when those cells are activated, if they don't receive a negative signal, then the virus, if they receive a negative signal through PD-1, LAG3, or TIGIT, those immune checkpoint molecules, the virus would be able to persist. But if they receive a positive signal and you block the negative signal by an antibody, then you would get reactivation and clearance. So this is what you want to do to really reactivate the virus. So we hypothesized that by blocking these PD-1, LAG3, and TIGIT molecules, we would be able to wake up the virus from the reservoir. And as a proof of concept, we did some experiments in vitro, and we found that actually it seems to work when we get these cells and put them in vitro in the presence of a blocking antibody to one of these molecules, which is called PD-1, we are getting more virus reactivation. And we did the same experiment in another system with another kind of reactivation, and again, by using these blocking antibodies to PD-1, we are getting more reactivation from these latently infected cells. So it seems that blocking these immune checkpoint blockers is really, blocking these immune checkpoints is really a way to reactivate the virus more efficiently, make it visible to the immune system, and maybe eliminate or at least reduce the size of the viral reservoir. And actually, Sharon published recently a paper in which she had a proof of concept for a clinical for a treatment with these antibodies. This is a different antibody against a different molecule from the same family, and she observed that this is a cancer patient, so who received this antibody for treatment of his cancer, and is also HIV infected. And when she measured viral reactivation, so reactivation from the latent reservoir, she observed that after administration of this antibody, the virus got reactivated. Okay, so this is my last slide, my conclusion slide. I think reaching or getting a cure is not going to be easy. And we'll probably need to combine different strategies if we want to significantly impact the size of the reservoir and also be able to control this reservoir after reduction. So what do we do to go from care to cure? Care would be a regular antiretroviral therapy, and cure would be no virus at all, or at least a controlled virus. Well, there are different steps. The first one, of course, is HIV replication. I think antiretroviral therapy is actually quite efficient, and as we've heard from Jintanat earlier, if you start antiretroviral therapy early or even late, usually you can get viral suppression very efficiently in your patients with triple regimen if the patients are compliant. Something more challenging is probably to try to inhibit viral application in tissues. When I started my talk, I told you that maybe some of these drugs do not go into tissues very well, do not reach their optimal concentration, so we probably have to design better drugs that have the ability to reach those tissues to really inhibit any new event of infection. And I think this is something that is actually quite achievable. The main problem with HIV eradication, and this is the reason why it deserves two steps on my stairs, is the latent reservoir. So this latent reservoir, again, is established very early in infection, and it's hard to reach. So what do we do? So again, HIV replication, we have antiretroviral therapy, works well in most of the patients. HIV in tissues, maybe we can try to optimize ART. Some of these drugs penetrate more efficiently in some tissues than others. So maybe by selecting a cocktail that has the ability to go into lymph node, gut, we would be able to reach a level of suppression that is way better than with regular treatment. So for the latent reservoir, again, this main obstacle to virus eradication, we can first start out in acute infection. And to date, this is actually the only way you can really affect the size of the reservoir. So I really want to stress out that the best way to impact on the size of the reservoir is by starting treatment very early on. And as Jintanat said before, the earlier, the better. So what do we do then? Well, if the latent reservoir is established, and it will most probably be established because even in very acute infection, there is establishment of the reservoir in a few number of infected cells. Well, then you have to try these curative strategies. So either you try to reactivate with shock and kill, and you can try also to boost the immune system to control this latent reservoir. I'll present you some data with PD-1 or CTLA-4 antibodies. This is an effort that we are pursuing with Sharon right now on different projects. And I really believe that these immune checkpoint molecules are interesting for a very good reason, is that they can do both at the same time. So basically they can reactivate latent HIV, and at the same time they can boost the immune system. So it seems to be the magic bullet, but we know there is no magic bullet, so we have to do the experiments and see if it works or not. So finally, I'd like to thank a lot of people who have contributed to this work. These are people in my lab, mainly for the acute infection study in Bangkok, Louise Lair and Martha Massanelia and Rémi Fromentin. Of course, the many collaborators, and I'm sorry because I was not able to list all of them here at the Thai Red Cross and MHRP, also our collaborators from Merck and McGill, the founders, and most importantly, I'd like to thank the study participants who have been very generous in giving their blood, their tissue, and also have contributed a lot to the data I've shown today. Thank you very much.
Thank you so much, Nicolas. That was great. Does anyone have any questions? Yeah, go ahead, please.
Hi, Dr. Chomont. Thank you for your talk. My name is Sun Nguyen. I'm from Vietnam. I have two questions for you. The first one's regarding the shock and kill strategy. Do you think the reason that the shock and kill strategy does not significantly reduce the latent reservoir is because the cells that we expect to kill the activated cells, such as CD8 T cells in lymphoid tissues where the latent reservoir is, might have different characteristics and they don't kill in that tissue, for example.
Yeah, this is actually a very good hypothesis that has been tested quite recently. So there are two things that you can think about. The first is the fact that some of these drugs might have a negative impact on the capacity of CD8 T cells to do their job. There's a paper from Brad Jones showing that some of these drugs, again, can impair the functional activity of CD8 T cells to kill and proliferate. So that's possibility number one. Possibility number two is the fact that the reservoir is hiding in what we call the B cell follicles of the germinal, in the germinal centers of the B cell follicles in lymph nodes, and those germinal centers usually exclude CD8 T cells. So it's possible that CD8 T cell could not reach those target cells and then won't be able to eliminate them.
So my second question sort of relate to the TFH population.
I'm sorry,
my second question relates to the TFH populations and the checkpoint inhibitor strategy. So, TFH also expressed a high level of PD-1 as well, right? So if you do anti-PD-1 treatment, you potentially can increase the populations or the size of the potential targets. So do you consider that as a potential side effect of the anti-PD-1 strategy?
That's an excellent point, and that's actually something that we've thought about. So you're right, TFH cells express lots of PD-1. So we don't know exactly what's the impact of blocking PD-1 on TFH cells is going to be. We have not done specifically experiments on TFH cells from lymph node to see what's going to happen with that, but this is actually planned in the project that we are doing with Sharon right now.
Thank you so much. Thank you, Nicolas.